well next week. Same time as always, but please look for him in the emergency room. Show him around the hospital. Show him around the ER. Ask him for his advice. Teach him, what your guys are learning about as well. So hopefully it can be a win-win for everybody. But Harrison, if you want to just say hello real quick.
Yeah, absolutely. So my name is Harrison. I'm one of the second-year residents at the University of Utah. Like Scott said, I'll be coming out in a week, hoping to learn as much as I can. And I really appreciate you hosting me over there. I'm really excited to come see where you work and how you guys practice. So looking forward to meeting everybody in person.
Sweet. Thanks, Harrison. Oh my gosh. Losing control of my PowerPoint slides. Here we go. Okay. I can't see anybody right now. So if you have a question, please just blurt it out at any time. But let's get started. So yeah, this is part 2 of our abdominal pain. So today we're going to be focusing mostly on when to get imaging, and then also some different nuances about imaging. And then we'll go through some cases, some hands-on kind of stuff, and hopefully wrap it up before the next hour. So the first question is kind of like, when do we need to get imaging in abdominal pain? Abdominal pain is the most common presentation to the emergency department, and we can't image every single patient. In general, there is no exact answer, unfortunately. However, you should be more likely to get imaging in a couple of situations. So the first one here is in patients with prior surgery. Especially if the surgery is recent, they're at a significantly higher risk for post-op complications in the short term, and then also like within like a few weeks, up to even a month or so, as far as ileus, perforation, obstructions, and abscesses. And there's not going to be any blood work or physical exam tests that you can do to look for those types of things. And so that's why we have to get our imaging. Furthermore, months, years, decades down the road from patients who've had surgery, they're also more likely for small bowel obstructions. They're more likely to have hernias. And so those patients as well consider the rest of their story is pretty benign. The most important situation, I think, is the next one, and that's in older patients, especially patients who are like approaching the 60, 65 years old. These patients have a significantly higher risk to have surgical pathology, and also at the same time often have a less concerning abdominal exam. So they can trick you kind of in both aspects, where their abdominal exam is maybe not that impressive. Maybe they're only a little bit tender, or maybe they're like, oh, it just kind of hurts, but you're not making it worse when you press on me. And you might, maybe they don't need to get imaging, but I would suggest anyone really, when they're starting to get older, to get imaging. The last situation is when you're using your physical exam. And so when patients have diffuse abdominal pain, but then on the exam, they're non-tender and it's a non-focal, they're less likely to have surgical pathology. So in those situations, you could use your laboratory evaluations, you could use your vital signs, and then good return precautions to potentially send the patients home who don't have a focal exam, send them home. And if they end up having to later on become focal, they should return to the emergency department. So just discussing some imaging options. Our first option is an X-ray. It's really pretty limited use, unfortunately, as far as intra-abdominal pathology goes. If you are going to use it, make sure you're getting an upright chest X-ray and a KUB to look for free air under the diaphragm. If you don't get either upright or lateral decubitus, if you just have them supine, you'll probably miss that air. And that's probably the most important reason to get one of these image X-rays. And so if you're going to do it, make sure that they're upright or in the lateral decubitus, so on their side. It can, especially in the younger population, it can be more useful in showing volvulus, bowel obstruction, and sometimes kidney stone, but their sensitivity for these is really quite low. And so if you don't see those things on an X-ray, there's still a really good chance they have it. So our next imaging modality is ultrasound. Ultrasound is useful, of course, for rapid assessment. You guys know about the fast exam. You guys know about the rush exam. And so those are something you can do at the bedside in your critical patients. But it's also useful for more specific questions. So if you're specifically interested in the gallbladder or biliary disease, ultrasound can be really useful, and we're going to talk a little bit more about that in a second. And then ectopic pregnancy or ovarian torsion, it can be really useful as well. Just in general, ultrasound is going to be more specific but less sensitive. So it means that if you do find a finding, you can feel pretty good that what you're seeing is true. If you see someone who has a cholecystitis, you can feel pretty good that they probably do in fact have cholecystitis. But if your ultrasound does not show findings of cholecystitis, you have to have a question mark of maybe they still have it. I just wasn't able to find the right images, or maybe it's too early in the disease process. So it's more specific than sensitive. And then, of course, our last imaging modality, and this is really the gold standard, is a CT with contrast, specifically with contrast. For most of our abdominal stuff, we're going to be doing CT contrast just in the venous system, but you need to consider when to use a CT angiogram. That's going to be timed differently from the radiology standpoint. And so if you're thinking about aortic dissection, mesenteric ischemia, or any other type of vascular injury, you'll have to get a CTA. Just keep in mind that this is using a contrast that's injected at a high rate, and thus you need to have at least a 20 gauge IV in a large vein. But for your normal contrasted CT scans, you don't necessarily have to have a large IV or in a large vein. Some special considerations that we're going to talk about here in just a second are kidney stones, biliary disease, and all the different types of biliary disease. And then we're going to touch on contrast-induced nephropathy and talk about when you should avoid using contrast. So first, let's talk about imaging in kidney stones. We used to think we had to use non-contrasted CT scans. The thought was that the bright white contrast, that when it's flowing through the iliac and renal vessels, the same contrast is the same color as a kidney stone, and thus it could obscure or hide that kidney stone from being seen. In today's recent CT scans, and really actually it's been for quite a while, the technology is good enough that that's not really happening anymore. And there's a pretty good study that was done to address this. And so the study was called Contrast Enhanced or Non-Contrast CT for Renal Colic. In this study, they also discussed utilizing urinalysis and patient history of urolithiasis to help decide to do contrast or non-contrast. So these are just some of the highlights from that study. But you can see in the second line here, one thing to note is that of the 282 patients who did have kidney stones, 231 had red blood cell positive urinalysis, which means 18% didn't. I know that some clinicians like to use a urinalysis as kind of a decision point about whether or not they think this could be a kidney stone. But 18% miss rate is quite terrible. And so we really can't use a urinalysis, unfortunately, to rule out a kidney stone. The second part about this study that was pretty interesting is the amount of misses that happened for the patients who underwent a non-contrast CT. So 15% of the patients actually had a different diagnosis other than a kidney stone. And I think it was 9% of those diagnoses were missed by the non-contrasted CT. The small benefit that you gained by using non-contrast at the time was 4% had a 1 to 2 millimeter non-obstructing stone. So this is the type of stone that theoretically could be missed by a contrasted CT, although other studies have suggested that even then we're no longer missing these 1 to 2 millimeter. But as you guys would know, a 1 to 2 millimeter non-obstructing stone really isn't something to be worried about missing. Those are going to pass on their own. They're not causing obstruction, thus they're not causing harm or further scarring down the road to the kidneys. So overall, big takeaways: get contrast and don't use the lack of hematuria to rule out a kidney stone. But really, I wouldn't overthink it. I would just always get contrast of the abdomen, regardless of what you're trying to look for. So imaging in biliary disease, and we're going to get some kind of practice on this here in a second, but kind of the big takeaways: you have ultrasound or you have the contrasted CT. Most bodies in medicine suggest that ultrasound is the imaging of choice overall. And we're going to talk about here some of the pros of it. So the sensitivity and specificity is fantastic for cholelithiasis. It's greater than 95%. But that's just for a kidney stone, just for a gallstone. It's not talking about infection, where in the next line you see the much lower sensitivity and even lower specificity for cholecystitis. it also has a lower sensitivity for cholecystolithiasis. So although if you get an ultrasound and you see a gallstone, which you shouldn't miss based on the sensitivity that we see here of 95%, you might not have imaging findings of cholecystolithiasis or cholecystitis. And so in those situations, you need to use your clinical reasoning, whether that's your physical exam, whether that's vital signs, blood work, elevated AST, ALT, elevated bilirubin, things like that, leukocytosis, inflammatory markers, or you can get a CT scan. Additionally, of all the findings on ultrasound, whether it's fluid around the gallbladder, whether it's a thickened gallbladder wall, a distended gallbladder, evidence of free air, things like that, of all the findings, the actual most useful reason to use ultrasound is to figure out if they have a ultrasonographic Murphy's sign. So actually the most useful thing is not even an imaging finding. It's just whether or not when you put the probe directly over the gallbladder and try to compress it, does that cause them the most severe pain? And so think about this Murphy's sign as not just the presence or lack of pain, but actually is the pain the most severe at the point of the gallbladder. So if you're pressing all over the epigastrium, the right upper quadrant, the left upper quadrant, that's not a Murphy's sign. They need to have focal, most severe tenderness in the right upper quadrant while the ultrasound is pointing directly at the gallbladder. So our other modality in imaging in biliary disease is the contrasted CT. This is the imaging of choice in patients who are critically ill. So if your patient comes in and they have right upper quadrant pain, you think it sounds like a good story for something biliary, but they're also febrile, tachycardic, hypotensive, maybe they have altered mental status. I would really be going straight for the contrasted CT because it's going to show you all these complications that could be causing them to be so sick. So it's going to show the perforation, the empyema, if there's evidence of gangrenous cholecystitis, or has their abscess been developed, or nearby portal vein thrombosis. And also it can show you the reason they got this disease in the first place. Maybe they actually have a pancreatic tumor or a gallbladder tumor, or some other unrelated pathology that could be making them critically ill. Like they could have pancreatitis, small bowel obstruction, something completely unrelated to the biliary system. And if you had just gotten the ultrasound, you would have missed it. So I would suggest in critically ill patients going straight to the CT scanner. The CT scan, though, as you see, it does not see all the stones. So our sensitivity and specificity for cholelithiasis is much lower than ultrasound, but it's quite sensitive for cholecystitis, although less specific. But you can feel good that if you have a CT scan with a normal looking gallbladder, you don't need to get an ultrasound in addition to that. However, a positive contrasted CT and the story is not straightforward, then you might want to get an ultrasound to better try to differentiate what's going on. Sorry. So contrast-induced nephropathy. And real quick, actually, did anyone have any questions about this? I'm presuming that most of you all know about the different types of biliary disease. And so hopefully I didn't move through this too quickly. Okay. So contrast-induced nephropathy, this is sort of a hot topic in Salt Lake City or at the University of Utah right now. We just instituted a new protocol related to the use of contrast based on a patient's kidney function. And so I'm not sure if this is something that's being talked about frequently in Vietnam, but big takeaway is contrast should never be withheld in situations in which contrast is required to make a life-threatening diagnosis. Where I work, occasionally I'll order a contrasted scan and I'll get a call from a radiologist saying they have terrible kidney function. And I just have to advocate for my patient saying, I know that they have bad kidney function, but what's going to kill them right now is not their kidney function. What's going to kill them right now is if I can't diagnose their ruptured appendicitis or what other disease might be going on. But to dive into this a little bit deeper, CIN is defined as an AKI within 48 hours of contrast. And so that's an important note to understand. This is an acute process that they're talking about, which in the emergency room and really in medicine as a whole, this is not very patient-oriented. Patients don't care if their kidney function for 48 hours went down. What they care about is what's my kidney function 3 months from now? What's my kidney function a year from now, 5 years from now? And there has never been a study that has shown that contrast has harmed kidneys in the long term. There have only been studies that have shown CIN within a very short window. Though, despite all of that, this is sort of the current radiology guidelines, and this is actually what we adopt at the University of Utah. But in any patient who has a GFR of greater than 30, there is no current data support withholding contrast, and thus feel free to give it. You don't have to worry about doing any kind of other decision making. Just go ahead and give it. Don't overthink it. In patients with GFR less than 30, there is a possible association with CIN. However, it's unclear. But the University of Utah, our suggestion then is to give fluids, and the fluid of choice, based on one study, was that we should use 0.9% sodium chloride. Although I think if you have lactated ringers, that would be just as fine. There just hasn't been a study that I know of that's directly used lactated ringers, but they have very similar effects on the kidney. So I think that either would be fine. So you'd want to give the fluids before you give the patient the contrast, if possible, as opposed to giving the fluids afterwards. So you kind of want to load them up with plenty of fluid, so when the contrast goes through, it is being diluted. And then, of course, if they're on any kind of nephrotoxic medications, you could try to hold that for 48 hours. The kind of very specific patients who are on dialysis is also something I often think to myself, can I give this patient contrast? And the short answer is yes, you can still give them contrast. If they still have some kidney function, which the best way to figure out if they have kidney function is are they still producing urine? And if they are, then you can protect that small amount of the kidney that's still working. And you should consider early dialysis to remove that contrast from their body to protect the kidneys. But if they're not making urine, there is no more kidneys to harm, and you do not have to get any kind of dialysis at any time. You can pretend like they are a normal, healthy human. If their kidneys are so bad that they're not producing urine, your contrast can't harm them further. Any questions about that? So kind of big takeaway to summarize, if their GFR is greater than 30, you can feel pretty good about just giving them contrast. If it's less, you should consider any other imaging modality. But if for some reason you still feel like you need contrast, definitely pre-treat them with the fluids. And then patients with dialysis, you don't have to get too scared about giving them contrast as long as they're still going to have their regular dialysis appointments. All right, so now is when you guys are going to have to.
I just want to make sure, with the kidney stone, you usually use the CT scan with the contrast, right?
Yes, that's correct.
Okay.
Thank you for clarifying. All right, now is time for a case. I can't see your guys' screens. I don't know how to get that to switch. So I know Jane is on. If Jane, could you help facilitate picking somebody?
Sure.
To help run this case.
Okay, let's see who's on. How about Dr. Kit? We'll have you answer some of the beginning questions of the case.
Yeah.
Awesome. Okay, thank you so much. So this is going to be not too long of a case. So here's your beginning details. It's a 42-year-old female presenting with abdominal pain. You got a first set of vitals. They're listed here in front of you. You can see the heart rate's 102, blood pressure 106/64. The other notable thing is the temperature of 39. The patient appears uncomfortable, lying on a stretcher, holding their abdomen, and she just vomited kind of during your history taking. At this point, any immediate actions that you would like to do before moving forward?
I look at this patient had fever and Also, she has abdominal pain. I think she maybe have lametry in his abdominal in her abdominal. So first I will give medication to reduce fever and take her blood sample to
That's great so far.
Yeah, and evaluate her abdominal with ultrasound.
Okay,
And okay, I will ask about medical history, education.
Okay, perfect. So it sounds like, yeah, immediately you're going to get some blood work sent off, get an IV. It sounds like you're going to give some kind of medication for the fever, like Tylenol or acetaminophen. And then you're going to continue your assessment, do a physical exam, and sounds like you're reaching for your ultrasound pretty quickly, which I love. That sounds great. So you collect your HPI. I'm just going to kind of give it to you here, so I'm not going to make you ask a bunch of questions. But here's your HPI. It's the 42-year-old female. She's had 12 hours of progressively worsening, constant epigastric, as well as right upper quadrant abdominal pain. The pain feels sharp. It radiates to the right shoulder. She says symptoms began about 1.5 hours ago. That doesn't make sense. Sorry, that's a mistake. I think her vomiting started 1.5 hours. That's what that's supposed to say. She's been constipated lately and states she thinks this could be gas pains. Patient's husband also notes that she's had similar pain in the past, but has never had vomiting or pain that has lasted more than a couple hours. So based on this, you mentioned getting some like medical history. What other questions would you want to ask the patient?
I will ask about the history of gallstone.
She does not know about any history of gallstones. Not that she knows of.
And the relative to food. For example, when she take the pen was after he had after she had food.
Yeah, she did say that she'd eaten a pretty big meal, maybe an hour or 2 hours before this happened. But she said in the past sometimes she gets pain in the middle of the night when she hasn't eaten in a long time.
And about medication such as NSAIDs.
She does not take any medication regularly. Just kind of here and there for pain. She'll take Tylenol or an ibuprofen, but nothing regular.
I will ask about medical history, diabetes.
Yeah, she doesn't have any. She just has hyperlipidemia. That's all she's got. So just cholesterol. So I'm gonna I think you asked some great questions, and you asked about a relationship to food, which I think is really important for abdominal pain. That's a lot of our diseases are affected by that. Biliary disease, gallbladder, also pancreatitis, or possibly a peptic ulcer. So I think trying to get this association with food is really important. And then asking about medical history is really important. One thing also to ask about is surgical history. Maybe have you had your gallbladder removed in the past? In this case, she's not had any major surgeries other than a C-section. Many years ago, she had 2 C-sections. No allergies. You did ask about medications. She's just taking the atorvastatin for her hyperlipidemia. Right now, the last thing I wanted to comment on was social. I do think asking about alcohol is important in abdominal pain because of its association with pancreatitis, but also gastritis. So trying to remember in abdominal pain to ask about alcohol intake can help guide you one way or another. All right, so this was supposed to come up one at a time, but let's talk about what do you want to know specifically about the physical exam?
On a physical exam, I will figure out the tenderness in right upper quadrant, and find out the size of peritonitis. The patient may have gone gallbladder inflammatory.
Perfect. I think that's great. Honing in on the abdominal exam. Also, don't forget to listen to their lungs, that sort of thing. Although this sounds very much like an abdominal problem, this still could be something like a pulmonary embolism that's on the right side and causing pain in that area. So considering a broad differential still for sure. Anyone have any other? And I'll open this question up to anybody. But the broader the differential in the beginning of a patient interaction, the better. So so far we haven't done any tests. We have done our physical exam, and she is tender in the right upper quadrant. And the rest of our physical exam was pretty benign. What is your differential diagnosis for right upper quadrant abdominal pain / epigastric abdominal pain?
Anyone else can answer too. It doesn't have to be Dr. Keat.
The first patient have the fever and abdominal pain. I think so much about the peritonitis from the appendicitis. And then the differential, I think maybe because the female patient, we need to rule out ectopic pregnancy rupture dissection because the patient has the front pain and have the many pain in the past. The young female. Yes, adjusting. Maybe the pancreatitis.
Perfect. Yeah, I think you nailed a lot of the big ones, the life-threatening ones. Ectopic pregnancy, definitely can't miss that. Or peritonitis from like a ruptured appendicitis. We definitely don't want to miss stuff like that. And then you mentioned some of the more common ones like pancreatitis when it's up in the right upper quadrant epigastric area. So we talked briefly about the initial actions. You guys mentioned sending off blood work, and giving Tylenol for the fever. Anything else you'd want to get? And specifically, what kind of imaging would you guys want to do? It's all on the screen as well, but
I think maybe something else to consider is, and maybe it's not as common in Vietnam, whether or not this is a complication from a sexually transmitted infection, because here we think about at least Fitzhugh-Curtis syndrome, when you have more uncontrolled STD kind of inflaming your liver capsule and causing peritonitis and like right upper quadrant pain. So if she had any other complaints or risk factors, I would also maybe tailor my tests based on that too.
That's a really good idea, Jane. Thank you. Yeah, and in this case, I did mention like she did not have any vaginal burning or discharge, and no concerning sexual history or social stuff. But it's important to like that we made a point about asking those things so that we could consider sexually transmitted infection, PI, pelvic inflammatory disease, and Fitzhugh-Curtis syndrome in our differential. So here's the recommended actions that, these are what I would do. I make the patient NPO. She's tachycardic and has been vomiting. So I would give her fluids. I'd give her pain medication. In this case, I would probably give her ketorolac plus or minus an opioid, such as morphine. I'm giving her something for her nausea, and I usually use Zofran to start. I'm giving the Tylenol for the fever. I'm probably not starting antibiotics at this point. She is meeting SIRS criteria, but at this point, I think it's possible this is still like a gastroenteritis or a viral infection. And as long as she's not getting worse, I think I would wait off a little bit to see what exactly it is I'm treating. But in the meantime, I would send blood cultures, given that she has a fever and tachycardia, and I'm going to send off basic labs, including lipase, a pregnancy test, and a lactate. And then plus or minus a type in screen. I added it here, but a patient who's febrile and it has abdominal pain, there's a decent chance it's a surgical process. And so getting the type in screen sent off early so that you don't delay the OR is something to consider. And then we could do an ultrasound or CT. Someone comments on what they would do. Would they go for an ultrasound or a CT scan in this patient? I think both are reasonable decisions, but it's important, I think, just to think about it and then have a reason for why you chose one or the other. I actually just figured out how to get all of your guys' faces back up on my screen. So Dr. Duong, would you do a ultrasound or a CT scan in this situation? And then if you could tell us why you would choose one or the other. I hope I didn't pronounce that wrong, but Dr. Vu Kiet Duong. Thank you, Dai. Okay. Something is amiss there. How about Dr. Vo Min Phuc? Did I say that right?
In my opinion, I think ultrasound or CT is depend on what you have, what available. In my hospital, we usually should do CT scan, contrast CT scan, because in this area, maybe acute cholestatic. So we usually do CT scan for this patient.
Great, thank you. Yeah, I think a CT scan is very reasonable, especially if you don't have ultrasound available to you. Like we talked about before, the CT scan is going to give you more opportunity to diagnose things besides just the biliary, just the gallbladder, like a cholecystitis. It's going to show you things like the pancreas. It's going to show us things like ectopic pregnancy, bowel obstructions, appendicitis. Whereas an ultrasound, unless you're ordering multiple types of ultrasounds, you're probably going to miss things like some of those things. In this case, though, I feel like an ultrasound was also very reasonable. She has right upper quadrant pain that was associated with eating and associated with vomiting. And so it does sound like this could be the gallbladder. So I think both are good options. In this case, we'll get to the imaging after this slide. But here's the blood work. I'll actually just the big notable things is there is a pretty significant leukocytosis at 16.2. The creatinine is 0.9, which is important to note. Just that her GFR is okay, so we don't need to worry about contrast. And then you can see over here there are some changes to her liver enzymes. So her AST and ALT are both slightly elevated. Her total bilirubin is also slightly elevated, and her lipase is normal. And that's an important thing to pay attention to when you're thinking about gallbladder stuff. Is you always have to consider gallstone pancreatitis. So here's an ultrasound image. Let's see, Dr. Hotu, what do you see on this ultrasound?
We see the tick of the wall bladder. Maybe have the stone inside, right? I think.
Yeah.
One stone, one big stone. Yeah.
Yeah. Can you guys see my mouse moving on the screen? No.
My mouse?
I know. Can you guys see my mouse? Okay, yeah. So I'm circling. This is the gallstone here. It's the brighter white circle, and kind of posterior to it, you do get some shadowing, and so the things behind it are obscure. They're not as clearly detailed. And you see on this anterior portion of the wall, so this whole structure is the gallbladder, the black structure. The anterior portion of the wall, you can see looks thickened, and that there's also fluid on both sides of the wall, which makes you worried about pericholecystic fluid is what we call that. So there's evidence of inflammation. I do want to comment that the ultrasonographer here did measure this wall. And you'll notice specifically that they measured the anterior wall, because if you measure the posterior wall, you're always going to get an inaccurate estimate. And that's because of the shadowing of the gallbladder itself, but also any kind of stones or inflammation on the interior wall will actually make the posterior wall less detailed. And so we always want to measure the wall on the front side. It's going to be the most accurate. If you're measuring any other wall, you could get a bad measurement and make an incorrect diagnosis. So this ultrasonographer correctly measured the anterior wall, which is in this case was 7 millimeters, which is enlarged. The cutoff is 4 millimeters for a gallbladder wall. Sweet. So what is your diagnosis then based on everything put together? So you have a patient who's febrile, tachycardic. They have an evidence of a gallstone on imaging with inflammation, and they had blood work that showed some elevation in their bilirubin, AST, ALT, and a significant leukocytosis. What is the final diagnosis be? And or if you think that there's the diagnosis hasn't been completely made, if you think that we're missing information, you could make that argument. Anyone have any thoughts?
Cholecystitis.
Say that one more time.
The patient suffer from cholecystitis.
Yeah. You got it. Yeah. So this patient definitely has this patient definitely has cholecystitis, like you said. Thank you. Additionally, I think that there's probably evidence that this patient has choledocholithiasis, although we didn't see the common bile duct. So choledocholithiasis is specifically that the gallstone has now left the gallbladder and has become stuck in the common bile duct. And so it's not only causing disease to the gallbladder, but it's causing disease to the liver. But since this patient does have elevated bilirubin, and her AST and ALT are starting to rise, I would be concerned this patient could be developing cholelithiasis. And additionally, this case was kind of designed, I think, in this fashion, but because the patient also has a fever, that could be from cholangitis, meaning not only is there an infection of the gallbladder, but this infection has now left the gallbladder and is going up and down the biliary tree, and we call that cholangitis. So it's a larger infection. So I think gallbladder disease is not as straightforward as we often like to make it. And this case shows, I think, that there's different ways to diagnose it. There's ultrasound, there's CT scans, blood work is helpful, our vital signs, our physical exam. It really is a combination of all these things. And even then, there is an overlap between these different types of diagnosis. And patients can have cholangitis at the same time as cholecystitis. And that's actually pretty common. So how are we going to treat this patient? Anyone have any suggestions on what we need to do next? Because we made the diagnosis, but that's just half the job.
I will give the patient an antibiotic and then call the surgeon.
Perfect. I think that's exactly what I would do too. Definitely get general surgery involved. You could also, I would let general surgery help us make the decision, but they might want to get gastroenterology involved as well. They might consider doing an ERCP in this patient, given the fever, if they're concerned about the cholangitis. And then if you hadn't already started, definitely give antibiotics. We want to cover, we kind of mentioned some of this stuff last week, but intra-abdominal stuff, we almost always want to cover for E. coli, and additionally Klebsiella and anaerobes. In the gallbladder specifically, Bacteroides fragilis is a common microbe, but generally metronidazole plus some kind of third or fourth generation cephalosporin is going to cover all of those things. And so we use cefuroxime quite a lot, but ceftriaxone's fine. And there's a couple other options. So we kind of talked about this, but case review, just to reiterate, the diagnosis and overlap of biliary colic, which is just a gallstone that's causing pain, but is not causing any kind of inflammation or infection. It's not causing laboratory changes. It's not causing imaging findings. The overlap between that, though, and all these other things is not always straightforward, and there really is a lot of overlap. The diagnosis is a combination of all of these things. And no single test can rule in or out any of the above diagnosis. As mentioned before, what most people consider the best imaging for the gallbladder is the ultrasound, but it's going to miss about 20% of cholecystitis, which is 1 in 5. I probably see 5 people with cholecystitis every month, and I can't miss 1 out of every 5, or I'm not going to be a very good doctor. So it's not just based on the ultrasound. You really do have to consider what their pain is. And how long has the pain been present? What does their blood work look like? What do their vital signs look like? So in this case, just to summarize, we had ultrasound imaging consistent with the cholecystitis, but our blood work actually was suggesting that maybe choledocholithiasis or cholangitis was actually occurring as well. In this case, CT imaging from ultrasound and consultation may help us distinguish these, but even still, they may not. And we really have to advocate for our patients to get admitted to the hospital where they can have further management. Low threshold in general with biliary disease to start antibiotics, start them early, because as I said, you might start off as just cholecystitis, but if they're not treated, the infection can spread and they can end up getting worsening disease. So start antibiotics and get your friends, your surgical friends, to help you out. Just some kind of high points on acute cholecystitis. In the U.S., I couldn't find a study about this in Vietnam, but in the U.S., 20% of the adult female population has a gallstone, and 8% of males. But most of these patients don't have a cholecystitis. They only have, so if you see a gallstone on an ultrasound, you have to consider, is this what's causing the patient's pain today, or is something else causing the pain? And don't kind of get honed in on, oh, this is a gallbladder. I see a stone. This must be the gallbladder causing the pain. Or you're going to miss something else going on, like a pulmonary embolism or a pancreatitis or an ectopic pregnancy. So make sure that you really, truly think that this gallbladder with this gallstone is the current cause of the patient's pain. So something kind of general rule of thumb, it's likely cholecystitis if the patient has a gallstone plus right upper quadrant plane plus any of the following. So if their symptoms are lasting greater than 4 to 6 hours, this is no longer very likely to be biliary colic. This is more likely now to be cholecystitis. Similarly, the positive Murphy sign, biliary colic shouldn't cause a positive Murphy sign. So use the Murphy sign to your advantage. And then ultrasound findings. Of course, you have the gallbladder wall of greater than 4 millimeters, a distended gallbladder. Patients can get distended gallbladders and not have cholecystitis, but this is if the patient has right upper quadrant pain and gallstones and their gallbladder is distended, all three of those things at the same time, you have to be concerned that the reason the gallbladder is distended is because there's a gallstone stuck in the neck of the gallbladder. And soon they will start to show these other things. So you might have a distended gallbladder. That's the first imaging finding. But if you recheck their ultrasound in 2 hours, now their gallbladder wall is showing signs of inflammation. Now they're starting to develop fluid. And maybe now if you recheck their blood work, they're starting to show the elevated inflammatory markers. Some quick pearls. Asymptomatic cholelithiasis is extremely common. A serious illness can be missed if symptoms are attributed to incidental gallstones, and thus consider obtaining CT scan. If you diagnose cholecystitis on a CT scan, you really should have a very convincing CT scan or a convincing story, because the specificity for CT scans for cholecystitis is not very high. It's only 60%. So make sure that you're considering maybe obtaining an ultrasound, or if they just have a really convincing story, or the CT scan is really convincing, you're probably okay to consult surgery and get them admitted. This is the Tokyo guidelines, which is helpful. You can find this online, and anytime you have a patient who you're worried about cholecystitis, you can look this up, and it helps guide cholecystitis, and it gives you a suspected diagnosis or a definite diagnosis. And again, this is kind of going back to, this is not always straightforward, but if you have a patient who you think might have it and they end up with a suspected diagnosis, these patients need to have a surgical consult. So you need to call general surgery and help them weigh in. But it's all the things we talked about already. It's the Murphy sign, it's right up quadrant pain, fevers, elevated inflammatory markers, or imaging findings. There's also a Tokyo guideline for cholangitis. It's actually been shown to be a little bit more accurate than the Tokyo guidelines for cholecystitis, but it's very similar. You have these different categories. Again, you can find this online and plug this in. And there's also a third guideline that helps decide how severe their cholangitis is, which can help guide your antibiotic decision making. So we're gonna do some mini cases. These are really short, one slide long, just to kind of drive home some points. Could I get a volunteer? Someone maybe who hasn't been called on yet. These are really short. They're not too hard, but just to drive home some points. Or should I make Harrison do it, since he's going to pick on you guys next week?
I can run through.
Okay, sweet. So here is your for this mini case. It's a 40-year-old woman. She has obesity. She's got lipids, hypertriglyceridemia. She presents an episode of upper abdominal pain that started 2 hours ago while at rest. Several hours after eating, the pain lasted 90 minutes. It was associated with nausea, radiation to her right upper quadrant / mid back. Now it's resolved though. She no longer has any pain. She has normal vital signs and a negative Murphy sign. What do you think the diagnosis is?
Biliary colic.
Nailed it. Right on. So this is symptomatic cholelithiasis. This is biliary colic. And treatment, I just gave it away, but you discharge with close follow-up with general surgery. And give these patients really good return precaution. These patients are kind of like an impending cholecystitis. They didn't get it today, but they're probably going to get it soon. So a couple of quick pearls. Again, I said this earlier, but 70% of these patients who have gallstones will remain asymptomatic throughout their lifetime. And 10% will become symptomatic like this patient. And 20% will become symptomatic within 20 years. Sorry, 10% will become symptomatic within 5 years. So a lot of patients have stones. They don't all have disease. Here's a second case. Any volunteer to interpret this? I'll read it, and then I think you guys will feel confident with the diagnosis. So this time it's a 40-year-old with episodic right upper quadrant pain. It was severe and constant. It started 15 hours ago with vomiting, and now she's febrile, positive Murphy's sign. It did start after a fatty meal. What's the diagnosis in this one?
Cholecystitis.
Awesome. Yeah. So this is acute cholecystitis. Some quick pearls on this. Note that the pain here started 2 hours ago. This can actually help differentiate peptic ulcer disease, which usually starts within 30 minutes. So this story certainly could have been caused by something besides just the gallbladder, but that's pretty helpful. Also note that fasting can be a risk factor for gallbladder disease because it leads to gallbladder hypomotility. So if you're not eating, the gallbladder is not moving, and thus it can become obstructed. So sometimes these patients come in the middle of the night and they haven't eaten, 10 or 12 hours. And that can be another way that gallbladder disease can present. All right, this is our last case, our last mini case. This is an elderly woman with a history of cholelithiasis, presenting with a 2-day history of intermittent fever associated with constant right upper quadrant abdominal pain and new onset confusion. On physical exam, she is febrile, tachycardic, hypotensive, jaundiced, and lethargic. So this lady is super sick. What's your diagnosis here?
Sepsis from the acute cholecystitis.
Yeah, I think acute cholecystitis certainly could cause this. She is jaundiced, though, so there's something slightly more going on than just cholecystitis. It's the cholecystitis. Oh, go ahead.
Yeah. Sepsis shock.
Yeah, I think this patient does look like she's in shock. I also agree with that. What do you guys think is causing her shock? Where do you think a gallbladder could have? What kind of gallbladder would cause, or what kind of gallstone would cause jaundice? Where would the gallstone have to be?
I think she may have the gallstone may stuck in her common bile duct and may have had acute cholecystitis.
Yeah, that's perfect. That's exactly what happened. So this is cholangitis. This patient has the jaundice plus all the evidence of the cholecystitis. So some quick pearls on cholangitis are to remember to get blood cultures. Up to 70% actually of patients with cholangitis will have positive blood cultures, which I didn't know that until I made this lecture, but that kind of blew my mind that it's that high. So make sure you're getting blood cultures in these patients. So they're actually going to be really helpful. And then the Charcot triad, which we talk about that a lot here in America, but this triad of abdominal pain, fever, and jaundice, it has a really low sensitivity. So only 1 out of 4 patients with cholangitis are going to show up with those 3 things. And so any patient who has right upper quadrant abdominal pain, cholangitis, you need to at least think about it because they're not going to present with all of these symptoms every time. So you need to look at their blood work. You need to look at their vital signs, consider the imaging as well. And then the Reynolds pentad, which is the Charcot triad, plus now they have altered mental status and shock, which is actually what our patient has. That's even less common. That's only in 10% of patients. So you're going to miss this a lot if you're relying on these kind of classic presentations. These patients do not present classically, unfortunately. Here's just some more slides with some ultrasound images on it. So over here on the left, we see lots of stones. We see lots of shadowing. Otherwise, though, this gallbladder doesn't show any bad signs. The wall is not thickened. I don't see fluid around the wall. It is distended, though, so I would be worried about this gallbladder in conjunction with some blood work to be definitely causing potentially cholecystitis kind of soon. But these gallstones aren't in the neck. But this other one, this is a gallstone that is in the neck, and so we can't see the rest of the gallbladder here, but this gallstone is right in the neck. You can see that this wall is definitely thickened, especially when you compare it to this other side. And this is a second gallstone as well. You can see the shadowing of these gallstones. A couple more pictures, pretty similar pictures. They're both showing gallbladders that show signs of infection. This one over here, you can see the sludge down here. This is all inside the gallbladder. And this is another example of why you shouldn't measure the posterior wall, is because I don't know where the sludge starts and when the wall starts. It kind of all just mixes together. So make sure you're measuring the wall on the anterior side if you're going to diagnose the cholecystitis. And then there's evidence of gallstones way down here in the neck, and you get the shadowing as well. But you can see when they're in the neck, they're harder to see. And so be careful to make sure that you're looking down there in the very neck of the gallbladder. That is all I had. I did introduce Dr. McCumber already. But he's going to be helping give the lecture next week on January 18th. It's going to be the same time as always. Any questions about anything today?
Can I have a question about the MRI in acute cholecystitis? The difference between the CT scan and MRI, more specific, right?
The difference between CT scan and MRI, is that?
Yeah.
Or between ultrasound. I don't know off the top of my head. MRI for the cholecystitis. We don't do the MRI unless you're talking about MRCP, which is a specific type of MRI. But the MRCP is the best test, but it's also more invasive and time consuming. So it's difficult to do from the emergency department sometimes. Gastroenterology. But if you have a case where you're not sure what's going on, you think there could be cholecystitis, you're worried there could also be choledocholithiasis, or that there's that stone that's in the common bile duct, the MRCP can help you visualize the common bile duct and see if there's an obstruction there. So it's the most sensitive and specifically for stones in the common bile duct. That's when the MRCP is really useful.
Awesome. And the other time I really like doing a bedside ultrasound is if you have a very, very obvious diagnosis on bedside ultrasound. It's so easy to get. And if you have a surgeon that is also very open-minded, you can get things done so fast for the patient, start antibiotics, send them admitted upstairs to the OR rather than waiting for a CAT scan and then waiting for the read for the CAT scan. But I only find this easy to do if they have all the findings and the stories match, but it's just something to keep in mind.
Awesome. Thank you, everyone. I know that this lecture was probably a lot of information. I kind of skipped over some of the basics because I know you guys know most of that stuff. But if any of this felt like a lot of information, the MRAP section on biliary, on gallbladder disease is really good. And I would suggest reading through that to make sure all of this sticks and you guys can apply it on your next shift. All right, well, have an awesome rest of your guys' week. Thank you guys for participating and great answers today. Thank you, Dr. Dye.
Sounds great. Thanks, everybody.
Thank you. See you
Thank
next
you.
week.
See you soon.